Welcome to session 9, and the topic of discussion is breaking bad news. I think that's one topic which is probably most difficult and most challenging in terms of actually doing the task. So especially those who are doing, breaking of bad news and handling situations, they would really understand. Not only they, but anybody who's in healthcare, they know a lot of time aggressive reactions happen after you break bad news to the patient's family. So, if I may ask you, what is bad news, by the way? What do you think is bad news? Maybe you can write in the chat box.
Ma'am, anything which the recipient feels unhappy.
Okay, done. That's fine.
Madam, unanticipated events by the patient or relatives.
Correct. I mean, even a simple adverse reaction to drug could be a bad news for them because they were not anticipating something like this. Yes, Rabinder, I agree. Life-threatening diseases, of course, are a big bad news for the patient as well as for family. What else?
Cost escalation, ma'am.
Cost escalation, especially if it is unexpected and there's a huge gap. Yes, it becomes a bad news for the family.
Need for medical legal.
Yeah, especially when you say, okay, we need to go for, postmortem. So sometimes they don't expect, so that becomes a big thing. Yeah, critical condition is definitely. So any personal experience of somebody hearing it for oneself or had a taste of it? Okay, customer not in a state of acceptance. Yes, Anandita. Patient, I will say patient, because I think it's more to do with. So I share my personal experience here. It's been like it was around say maybe 20 years or maybe more than that, 25 years ago. 25 years ago. So I had, a little pain in my while breathing. I had pain in my chest and also right on the right or left. I don't remember exactly which side. I had difficulty, and then while breathing, there was a severity of pain on one of the sides. So I like discussed with my husband. He said, "Let's go and meet, the physician who's nearby." So we went to his friend and he examined. He said, let's get the X-ray done. So we got the X-ray done and there was small shadow on the lower lobe side. So he said, I don't think there's much to worry, but still, we'll start with the antibiotics, and if things go okay, then fine. Otherwise, we'll have to investigate for tuberculosis. So knowing this, that maybe there's a possibility of tuberculosis, I had to like wait for 3-4 days before actually to get my X-ray done once again. Those 3-4 days for me were like my whole world came crumbling. My kids were very young at that time. My younger daughter was, I think, just 5 years. Elder one was 10 years. So, and we are a nuclear family. And I was, completely helping my husband with his clinic, and I had my own work also. For me, everything changed completely. I said, who will look after my family? Who will look after my kids? Will I be able to hug them? Will I be able to feed them? Will we be able to sleep together? N number of things I had on my mind. And those 3-4 days, like I was completely, though we know that tuberculosis is something that's after medication, proper treatment, you lead a normal life, there's nothing. But imagine, in spite of knowing all that, it came as a huge shock to me. Thankfully, after 3-4 days, when we got the X-rays done, everything was fine. There was nothing to worry. So it was simple infection. It was got maybe went to the lower lobe. But imagine when it comes to us, even simple diagnoses like hypertension, diabetes, arthritis, even these become bad news, isn't it? Dr. Abhishek, you have raised your hand, so I think you wish to share some experience. Please go ahead.
Yes, ma'am. It is actually very serendipitous that you're talking about tuberculosis.
Mhm.
2020, just when the first wave of COVID was settling,
Mm.
before that, I had noticed a small little swelling in my neck here.
Mm.
Being a doctor, all kinds of dangerous differentials was running through my head, and I kept postponing it and postponing it because I just didn't want to find out.
Ah.
Eventually, when some other senior
no.
doctor pointed it out to me, is when I realized that, okay, I should go and do something about it.
Mm.
Long story short, it turned out to be a cold abscess, and the investigations were done. And what I feared that it will be tuberculosis, it turned out to be tuberculosis. And
Mhm.
I treat tuberculosis myself.
Mhm.
But still, when I saw the report, I just couldn't handle it. And I literally took a break for 7 days from the hospital to process that information because I just
Mhm.
couldn't believe that I was having this diagnosis. Though I know the drugs, I know their side effects, I have first-hand access to the best of chest physicians in Bombay.
Mm.
But when I was on the other side, it was a completely different ball game.
I can completely understand. At the same time, I think it should give all us an idea that when we say simple things like hypertension, diabetes, all these things, we don't even consider that they are any bad news. Even they affect individuals very adversely. And for them, I've seen people, like in my husband's clinic, sometimes if the mother gets to know that her child is going to be using spectacles because probably child is high myopic or hypermetropic, they literally cry because for them it's a shock that their child has to wear spectacle, and then they say इतना छोटा बच्चा है कैसे पहनेगा कैसे संभालेगा स्कूल कैसे जाएगा बाकी बच्चे क्या करेंगे मतलब all those sorts of concern, and they're so genuine concerns if you look at them. So I think today's session, it's though we are going to take a very serious condition to discuss as a role play, but when we are giving diagnosis to patients, and especially which has some kind of serious and adverse effect, or it's going to affect patients life and future, I think we need to be more understanding that how it is going to impact the patient or patient's life. I remember MBBS student was brought to me by his parents that teachers say that this child has some health issue, mental health issues. So please, can you write and give us that there's nothing to worry, and child is okay. So when I went into the detail, he was a clear-cut case of OCD. So their major concern was that please write everything is okay and he can go for he can join his college back and go ahead. And when I told them that this is a condition, it requires a psychiatrist intervention, and you will have to visit a psychiatrist and take medicines, and also whatever other things need to be done. And then maybe your psychiatrist will give you clearance that yes, he's fit to go for his classes. But then imagine parents' plight. I mean, for whom the child has done a lot of effort to get into a medical college, and then within few months he suddenly becomes he's affected by this condition. It becomes very difficult for the parents also to accept something like that. So I'm sure all of you will have some or the other experience where parents or patients were really affected very seriously, and it was something they were not expecting. So those who are doing the breaking of bad news, I know it's medical professionals who do the breaking of bad news. So what kind of bad news are you normally sharing? If you can write in the chat box. What are the common, bad news that you normally share with your patients? Yeah, Ravinder, you have written deterioration. Yes, I agree. Deterioration is one. It's a bad news. Death, yes. Critical condition, yes. You see when the patient's condition is deteriorating or it is critical. Absolutely. Diagnosis, yes. And then unexpected neonatal event after birth. Oh, yes, that can be really very shocking for parents, children, and family. Uh, Death, I think, becomes the biggest. And cancer, yes, cancer is also another concern. HIV, when we give that diagnosis, that's also very shocking for the, or infertility, even that's a shock for the family that you will not be able to conceive. Just the other day, like I think it was at Kerala when we were discussing this case, that a man, when he was, he had some condition, he went to his doctor, and then I mean, in a little insensitive way, probably the doctor said that probably you have cancer of penis, and you will have difficulty. I mean, he must have discussed what difficult, and it was not even a diagnosed and well, confirmed diagnosis. Can you believe that fellow, on the way he committed suicide? And unfortunately, his wife was already pregnant with few months of pregnancy, and she delivered the baby after his death. So you can imagine how this can affect anybody's mental health. Yeah, cardiac arrest, yeah, anaphylaxis, perioperative myocardial infection. Yes. So, I mean, lot of conditions you're talking about. Yes, cardiac conditions is one of the, just 1 second, I need to take this call. Oh, I'm sorry. Yeah. So if these are the things that you are communicating to your patients, if I may ask you, how do you prepare yourself for breaking this kind of bad news, especially mentally and emotionally, before you actually break the bad news? If somebody would like to unmute and speak, because this is not possible to write down at length, but if one of you could share your experience, do you do any special mental preparation to go ahead? Dr. Abhishek, you wish to reply to this?
First of all, I take into account who is going to be there for me to break the bad news to.
Mm-hmm.
I see to it that there are at least couple of people.
Mm-hmm.
Personally, I think
Couple of people from your side or from patient party side?
From the patient side.
Okay.
In case if it's in the ICU, I take help of other doctors, the ICU head and other, if any intensivist is there. I see to it that I can answer, I anticipate what questions they'll ask, and I'm able to answer that. If it's in the OPD, I don't have anybody else around with me, but I see to it that again I read up if it's something I can prepare myself, so that if they will have any question, I can be able to answer them in the best way possible. So I do some preparation before.
That means reading about the case properly and then knowing all the information, so that
yes, especially if it's a cancer diagnosis and I have to give or something like that, then I do because as internal medicine, we don't study entirely about oncology so much, but still I am the primary person they come in contact with, then I have to direct them to the oncologist. So I do as much reading as I can, but if it's in the ICU, any critical condition, heart diseases, I make sure I can anticipate what question they will ask, and I have read up for that.
One has to really prepare, so that in case if they ask any question about the options available and prognosis or
yes.
So you should, wonderful. I'm sure everyone needs to know. My next question, and I Dr. Bijoy, if you wish to answer, or Dr. Purnima, if you wish to answer, is how do you prepare? I mean, how do you balance between honesty and then sensitivity, because we are going to break the news, and of course it's going to affect the patient. How do you balance between sensitivity and honesty? Dr. Bijoy, if you wish to answer.
Ma'am, I didn't get your question.
Okay, so we have to tell the truth to the patient. Whatever the diagnosis is, that has to be communicated very honestly. But a lot of time, if we communicate it honestly, we get to hear this from the patient party, that we were not very sensitive to the impact it will have on the patient. Like, for example, I know one of my known to had gone with his sister she was under treatment for cancer, but she was cancer free for 5 years. So once she had relapse and she had metastasis, she went to the oncologist, and I don't know in what way, he said, He said, 5 साल जी लिया आपने, बहुत बढ़िया हो गया, मुझे तो लग ही नहीं रहता कि 5 साल तक निकाल पाओगे आप टाइम. So see,
Yes.
I mean, you were honest. Maybe you didn't expect the patient to survive for 5 years, but the way you put it across, sometimes it comes as though we don't even realize what we are saying. So I want to understand from you or from Dr. Som or Dr. Purnima, how do you balance between honesty and sensitivity? That's my
Yes,
question.
ma'am. Yes, ma'am. That's a tricky question because
Yeah.
actually it depends upon the kind of bad news which we are going to break actually. Okay,
Mm.
if it is a death scenario and the patient
Mm.
is in ICU, as an extension to what Dr. Abhishek said, we will just delay the bad news, but we will just give it the worst, like patient's condition is very critical, something like that. We will just try and we'll just give them lack of hope or something like that. That is
Mm.
one strategy which we used to do usually. Like
Mm.
within half an hour, during half an hour, we used to continuously give some bad inputs. Like patient would have been kind of a dilated pupil scenario, but we will be saying he's not responding to drug. His condition is very critical. It's
Mm.
you are extremely lucky if he goes till tomorrow. Those kind of things we will say for an ICU setup.
Mm.
And for remaining things, I think depends upon the conditions. We will have to do our presence of mind.
Mm.
So I don't know. I think someone else will add up to that.
So that means, yes, what you are saying is probably a very practical tip. Normally, when we know that death is inevitable, or even sometimes death has occurred, so you don't want to go and break it immediately to the family. Maybe you would like to prepare them for it and then you would announce. I think that's what you're talking about. That's perfectly all right. But when it comes to delivering, are we really well versed with the vocabulary that we should be using, which should communicate the truth, but still should not be this thing. I think Dr. Purnima wants to add something. Go ahead, ma'am. Please go ahead. Yeah.
Madam, based on my own personal experience as well as my own methodology, which I followed in my unit before these things became very much formalized,
Mm.
the main thing is that you have to be factual. You cannot sacrifice facts.
Absolutely.
Second is there has to be a balance between a clinical approach as well as empathy.
Mm.
So simple gestures such as making sure that you are accompanied by somebody from
Mm.
your team,
Mm.
that you are not breaking it to just one person.
Mm. Mm.
I'm not talking only death announcement here. I'm also talking about morbidities.
Mm. Mm. Yeah.
Actually, in a happy situation like a neonatal situation where they are in a happy frame of mind that the child is born and you are telling them something which they don't want to hear at
Mm.
that time. So from your team side, if at least two team members are present,
Mm.
this is what I followed. And from their side also, at least two people,
Mm.
probably from different age groups, are present because
Mm.
perspectives differ. You have to strike a balance between delivering facts, not watering down facts, and
Yeah.
with empathy. So simple gestures like offering them a seat,
Mm.
them the facts in a proper manner,
Mm.
giving them time to absorb, because
Mm.
we have already absorbed the situation and are relaying, but for them they are hearing it for the first time. There may
Mm.
be some usage of medical terms which is unavoidable, so
Mm.
breaking it down to their understanding. And most important in my experience, what I have found is giving them time to absorb and being open to questions and not labeling any question as silly or trivial. Also, if required, repeating the things
Mm.
and again giving them time to absorb and question you. This displays empathy, it displays openness, and it also displays that you have your facts right. Nowhere should you try to conceal the fact or try to water down the facts, because that is wrong. You have to do your duty as a medical personnel, but at the same time, you have to do it with empathy and mutual respect. Thank you.
Thank you. I think Dr. Purnima, that was wonderful explanation. Jana, you had raised your hand. I think you wish to say something.
Ma'am, I had an experience last year, basically breaking the news. I had my brother-in-law who was admitted, and he was diagnosed with cancer. And the doctor came, and the doctor was like, since he knows me, he told me he's not well. And then there were so many people telling me so many different things. But how do we break the news to my brother-in-law was a question. So we got him counseled first. Like, we asked a counselor to talk to him and make him prepared to hear the news. And that's how we told him about
Okay.
it
So you
together.
first approach through counselors. So
Counselors, yes. So he can accept it that he has got.
So my next question to all of you is, and if Dr. Som would like to answer because he has raised his hand, like, how do you confirm that the patient has actually understood? Because a lot of time we have seen that we have explained to the patient party or patient that this is what is the condition, but then at the end of the day, sometimes they say, no, we didn't understand, or we were not told, or actually they did not understand, and it causes confusion. So how do you make sure that the patient has actually understood? I think 1 second. Dr. Razak, we are discussing breaking bad news because you joined little late.
Yeah.
Yeah. So we
Sorry,
are
ma'am.
discussing.
Sorry, ma'am.
Yeah, no problem. So we are discussing breaking bad news, and I'm just trying to kind of have discussion, and I'm making people share their experience so that we learn from each other. So I mean, Dr. Som, I think is going to answer this question. That how do you confirm that the patient has actually understood?
Many times their emotions will show it up more than the verbal communication. Their emotions. No, I'm an acute care physician. I'm an anesthetist. One second, I'll just. Sorry, I think the fan was disturbed. I'm an acute care physician who deals with who many times end up breaking bad news about the unanticipated intraoperative events like anaphylaxis to antibiotics or unanticipated difficult airway leading on to tracheostomy, which has not been explained to the patients in the preoperative period. And probably in a vulnerable group where patients had ended up in having perioperative myocardial infarction or a massive blood loss, massive transfusion, and unanticipated postoperative ventilator support. So when I explain, many times we explain these things to patients' relatives, and few times we explain these to patients themselves afterwards. So the one key thing explaining about these things to the patient's relatives is I always talk to the patient relatives as a team. So the operating surgeon, and more importantly, I usually anesthetize patients whom I have seen the day before. So I know who is going to be with the patient. And especially if the patient is a high-risk patient, I make sure I sit down with them. I pull up the chair, sit with them, take a case sheet or a piece of paper and write to them, draw them if needed, tell them these are all the problems that might happen in your case. Like, for example, the patient is going to have an aortic aneurysm repair. I'm going to anesthetize the next day. So I will sit with them and then draw the diagram. This is aorta. This is how your blood supply is going to go from aorta to different parts of the body. They're going to replace this part of aorta. So you may end up having massive transfusion. You will end up in post-operative ventilator support. You will have.
So how much time do you spend, Dr. Som? How much time
it
do you
doesn't
spend approximately?
I don't mind till the time the patient understands. The patient party understands. That is an important thing because different people will have different levels of understanding and different intake times. And for some patients, it will be an shock. So few patients will say that my surgeon has not explained this in so much detail and in depth. So that will have important implications to them financially to arrange for them who will take care of their family, and so many other factors will come into play.
Yeah.
So such things will have in play.
Sudden developments definitely become difficult to explain, especially if they have not been touched any time before. So definitely if it comes as a sudden this thing. And I think there your rapport with your patient and your trust and your regular communication, I'm sure must be playing a big role.
When it comes to
trust in you, they have trust in you, and they know that whatever you are going to say or whatever you're saying is because that is the development and patient requires this intervention, and it is not something that you had planned in your mind and now suddenly you are bringing it.
I think explaining the cardiac arrest or death to the patients will be very difficult. So what I say is an analogy, right? Like, for example, if this complication occurs in a specific set of population, probably maybe when you undergo this procedure under spinal anesthesia, if all people in a city undergo spinal anesthesia, hardly 5 people will have this complication. And if all the people in a village undergo this problem, this type of surgery under anesthesia, probably 50% of patients will develop a problem. And you are a person in a village who
I think what you're trying to say Yeah, I understand your point. I think you're trying
Yeah.
to say when you talk with statistics, it makes more sense to them and they are able to understand also. Thank you. I think that was a very good
Yes, yeah.
input coming from
Okay.
you.
Yes.
I want our others to tell, are you using any specific tool, communication tool? I mean, or are you familiar with some communication tool, or what you're doing is by learning, seeing your seniors, or maybe, I mean, you were actually formally trained to do breaking of bad news. Dr. Razak, if you would like to answer, or those who are doing the breaking of bad news, they will be able to.
Actually, I do not have any tools or don't follow any rules, but um, always try to make adherent to the patient and have a communication and fixed up some of my staff to adherent to the patient and time to time uh, up to date to the latest update of the patient to their relatives. I think it will helps to sudden if we breaking the bad news suddenly, and if it is not into their intuition that the patient may become very much sick or patient may threaten their life, it will be acceptable. But uh, if it is accustomed, if it is prefixed in their mind, that, yes, my patient is very ill and his life is in danger, he or she will need ICU, and sometimes their life is actually in danger, then actually I think it will preferable to us to make any bad news to their relatives.
So I think in all cases we have to break the bad news in a very systematic manner. Today's session I think will help us. Of course, Dr. Som has written about spikes. There are many protocols available. There are many tools available. We'll be discussing a very short, simple protocol to help us understand how we can go about breaking a bad news. So what we will do, I think we'll do a small practice session that I want to give you. I will be sending two of you in one breakout room. So that means we are 12 of you. So I'll be creating 6 breakout rooms. But what I would want, I don't want the doctors to play the role of the person who's breaking the bad news. I'm sure you are already doing it. The reason why I want you to change your roles with the non medical person is to get into the position of a patient. A lot of time we are doing it so much regularly that it becomes a very regular thing for us, but sometimes to be in the patient's position also helps us create empathy. How would the patient feel? So let's take a situation that your patient is a young man or woman, and they have been diagnosed with cancer pancreas. It's a established this thing diagnosis, and you have to now pronounce this diagnosis to your patient. So are we okay with that? Okay, so I'm sending you to the breakout room, and you will get 3 minutes time to do the discussion and then come back. Give me a second to create the breakout room. So I've created the breakout rooms. You are requested to join the respective group. Please join the breakout room. Dr. Razak, you have to join the breakout room. Did you get the message? Simil, you need to join the breakout room. So, who was your partner? You are on mute mode. Your device is
Raminda, Raminda ma'am was the partner. I think she delivered the bad news to me.
Let everybody come in.
Yes.
Was it done seriously or it was more like fun?
It was more seriously, actually.
We started
Actually,
in a funny way, but it came out to be a serious talk later, ma'am.
Is it?
Yeah.
So
Ma'am, I'm sorry.
Sorry, ma'am.
Our discussion was not complete. I was
Without
not able to.
finishing my job, I am returning back to the main panel.
I deliberately paired
Sorry,
you
Miss Anita.
one medical and one non-medical person.
Yeah.
Thinking that
And I now realize how difficult it is.
that was the idea. That was the idea. Because we normally say, why don't they break properly? Why don't they talk properly?
Actually, I am not audible to all. I can hear all of you.
No, we can hear.
We can hear
What's the
you.
problem, ma'am?
Dr. Razak, we can hear you. Yeah. So those who were doing the breaking of bad news, what was your realization? One by one, briefly, I want you to speak.
It's Dr. Indu ma'am, it is very difficult to start the conversation. How to,
Okay.
yes, so the thoughts which come to your mind, and like you you have you have all the thoughts in your mind, like meko abhi inko batana hai, but then when you go in front of that person, it's very difficult ki main kaise bataun. So that I was facing that. That was a
So
difficult
normally we
thing
think
to
it's a very
start.
small thing. It's not a big deal, but yeah, I'm sure you got a feel.
It's a big deal. It's a big
It's a
deal.
very
It's a
big
very
deal.
big deal. Yes.
Yeah. How about others? Anybody else who would like to share their
Mom, I too felt the same way. I wanted to tell her, but I do not know how to start it. So
exactly?
I was searching for words. I
Okay.
was really searching for words. What I will tell.
But did you all do seriously? I did not enter the breakout room. You all did it seriously?
Yes, yes.
Okay.
We did try.
Yes, ma'am. Yes, ma'am.
We
Even
tried to
Aparna
do
offered
it.
me a coffee and all before uttering the bad news. So she did amazingly well.
That is
Okay.
not serious.
So how about others who were on the listening side, who played the role of patient? I want some of you to share your experience. What did you feel being there?
Ma'am, I have something to share. Like in HR, normally we kind of break the new so-called bad news to some of the employees if they are not performing well, and then how we have to say them. It is very difficult. Although the person may be very honest, very loyal, but now performance-wise not okay. So not coming up to the expectations. So in that case, sometimes we have to take a very hard decision and we have to tell them. So in that case, those kind of situation wherein I face and I have to communicate, like, wherein I definitely, it's not a good thing. I mean, I don't feel good, but I have to do that. So in that case, more I tell them what is expected from them, give them enough time to absorb, and I give more into, I indulge myself more into active listening. I allow them to talk and let them vent out.
Paranandita, I think these two situations, of course,
Yeah,
that is
different.
for
Yes,
bad
ma'am.
news for
For
somebody,
me, this
but
is the breaking the
I mean, life and death have a very different impact on
Yes,
individuals.
I agree. I agree.
So it can't be, I mean, honestly, it cannot be, these two
No,
situations cannot.
I'm telling what is close
Yeah.
to what the kind of
But
bad
you are
news that
already
we
doing
handle.
the job.
Yes.
Absolutely. Thank you. Thank you. So those who were at the receiving end, I want some of you to share your experience. How did it feel being there?
Yeah, it was good.
Briefly. Yeah.
Yeah, it was good. It
Hmm.
was about the surgery that my friend was going to go through,
Mhm.
and something that was explained very clearly that it's a minor surgery and it's being diagnosed, and it's going to take 48 hours time, and the patient will go back home and will take
Okay.
the proper precautions with the medicines and the
Hmm.
treatment. Don't have to worry. So it was like words of comfort. Although
So
it
how
was
did
bad,
it feel being there?
oh, it was good. It was comforting. At the same time, the news was something that was alarming also, but it was an assurance.
Oh. So I want others to share what was their experience and what were things on your mind when you were receiving it. If any, okay, Dr. Purnima, yes, go ahead.
Ma'am, I was fortunate to be paired with Miss Simil. So basically, she was to break the news to me of a confirmed diagnosis. I'm going to cut her performance into the points which were very good and something which has a scope for improvement. So what was very, very good about it was that she started with a general reassurance that in today's world, there is a treatment for everything. So that's a general reassurance. So that was comfort. Then second thing is then she realized that the scope of the news which she was about to deliver to me was very devastating. So she asked me that nobody was with me, and so she rescheduled with words of comfort, and she said that you report back to me at a time when somebody is there with you. So these two things, general reassurance, and second is proper scheduling to give the news of such great import. That was the two very noteworthy points. On the flip side, the thing is this, that the patient will continue to think until the next appointment. And second thing is that unfortunately for medical personnel, we don't want to hurt feelings, but sometimes we have to be factual, like I said in my earlier submission also, because let's not forget we are legally liable for the treatment. So therefore, that's why we realize the importance of today's session, that we have to combine empathy with science fact. Thank you, Mr. Mill. You were very kind to me.
Thank you. Thank you.
Thank you so much, ma'am, for your feedback.
So I hope these 5 minutes of activity gave you an idea of each other's plight. When we are on a patient's, in a patient's chair, I mean, how we feel, and when we are breaking the bad news, how difficult it is. I think we need to understand the challenges of both the parties, and then probably we can do it empathetically. So normally, patients expect the doctors to, tell everything honestly, but then empathetically. And this is not me who is saying, but number of studies have shown this, that the patients expect their doctors to be, to be more compassionate, and lot of studies have shown that almost 2/3 of the patients in multiple studies, they have reported this experience to be suboptimal, where the person who was breaking the bad news were not very sensitive, or they did not care much to see the impact of it on the patient party, and they did not address their concerns. And a lot of studies, I'll be sharing that with you. See, breaking of bad news is one of the trickiest and most difficult communication, as one has to be really, good at words, and then also handling emotions. And also there are emotional reactions coming from the patient side. So one has to really learn to control that and also handle them. And most of the aggressive reactions actually occur after the breaking of bad news. Am I right? Do you agree with me on that? So usually we see a lot of reactions coming, from the patient party, especially when you break bad news. And incidentally, younger generation doctors are experiencing more challenges, because if they are not trained, if they are not, if they haven't practiced, and all of a sudden, if you have to go and say something serious like this, something would come out, something that you that's not expected from you. So it requires a lot of practice. It requires, and role play is a very good way to learn how do you go about handling those situations. So breaking of bad news require advanced level of communication skills and great experience in handling emotions. So one has to be really good at words, and then of course handling emotion. Also at the same time, a word of advice that I wish to, give to all of us is that we must build good rapport with every patient, and create an impression that we care for you, and we are concerned about you, and we look after you with great responsibility. Because we never know which case might suddenly become an emergency, and we may have an unanticipated outcome. So there, if you have good rapport, that trust patient has on us and on our team, that we won't do anything, carelessly, or we will not be irresponsible in their management. Unfortunately, if something unanticipated, happens, they still pardon us for that, or they overlook that, thinking that you haven't done it willfully. Unfortunately, if we haven't been able to, build rapport with them, win their trust, not updating them, not addressing their concern, trust me, that becomes one of the biggest reason that the moment we break bad news, they assume, especially if it is unanticipated. Of course, diagnosis is something they would still accept, but in treatment, if there's a deterioration or the or sudden, changes in the condition, they normally think that we have mismanaged it. So therefore, creating familiarity and rapport helps in reducing the risk of violence and aggressive reaction coming from the. So for that, I think keeping the patient party regularly updating, answering their questions, addressing their concerns, and also involving them in decision making. If we take care of these things, I think this goes a long way in winning their trust that everything is being done as per the treatment protocol. Of course, transparency and honesty plays a very big role. If we haven't been able to practice that, you can expect them to blame us for hiding things or not coming out with it. And at the same time, I think let's understand one thing, that when the patient is in serious condition, the family is looming under one of the greatest fear of life, and that is fear of death. Anybody's behavior will change if somebody gets to know about something like death or some complication. And studies have shown that many of us look after the patient very well, but we do not look after the family's emotions, family's state of mind. So as a result, they not only become upset, they already have pent up emotions. They're already annoyed with us for a number of reasons. But because their patient is under our care, so they kind of control themselves. But the moment we announce death or something that's inevitable, so they kind of, they have nothing more to do. That is where you will see that they would break their control and they may become aggressive and violent and all sorts of reactions we get to. So I think let's go through the protocol that I want to share with you. Many of you are already practicing, many of you know it. But the whole idea is that if we know the protocol, we'll do it in a more meticulous manner, in a more careful manner. And also at the same time, residents and nurses working in critical care areas, especially ICU, labor room, OT, emergency care, we all need to be more sensitive to the patient and the family's emotions also. A lot of time we are very rude and aggressive with them and non-cooperative with them, especially sometimes when they say we want to see the patient, and if we know that this patient is not going to make it, and if we don't allow them to see, and unfortunately there's death before the next visiting hour, they're going to all their life blame us for not being perfect. So we really need to be more compassionate with especially patients who are critically ill and we know that they are not going to make it. We have just maybe few days or few hours. So let me share the screen and share the protocol with you and discuss it further. Give me a second. So I hope my screen is visible to all of you. Okay.
Yes, it is.
Yeah. So this is a very simple protocol that I'm sharing, and there are a number of protocols available. One can actually, have a look at multiple protocols to finally choose what works for you. So when the patient is in critical condition, I think updating the family and breaking of bad news should always be done by the senior most person present there. So we can have juniors who can observe, who can be there to see and learn. But when the person who is treating, the doctor who is treating the patient, when he or she does the breaking of bad news, family knows the patient, doctor. They have already developed rapport. They have already had a lot of interaction. So it becomes easy to build rapport and also then to explain to them. So in this protocol, there are 4 P's. The first P is about preparation, which talks about preparation of the physician, place, and patient. Second P is performance. How do you go about doing it? Palliate and then plan. Let's discuss all 4 one by one. So when we say preparation of the physician, that's basically before you go to announce something to the patient or the family, it's very important to know and confirm the fact. A lot of time we have seen that if we go unprepared, for example, if we have not seen all the reports, if we are not aware what investigations were done, have we received all the report, or is this report really belonging to this patient? A lot of time we have seen even mismanagement of the reports, and then we go and announce something to the patient, and then we realize, no, this report was not for this patient, but for somebody else. So it's very important to know properly about the patient and the report and everything, and then confirm the facts before you go and talk about the report or the diagnosis with the patient. So before you actually start talking about the diagnosis, it's important to make connection with the patient and the family. For example, even if you ask about how are you feeling or what are your symptoms, are you feeling better, how is fever, how is pain, how is bleeding, so that is kind of, you are starting your discussion about the condition. Then be mentally ready to spend some time in case if you are thinking that I will do it at the end of the day when I'm going, or I will talk to them when I'm free from everything, or in case if you have something like you have an OPD or a case lined up or a visitor waiting for you, I don't think if you will show that kind of hurry or urgency to move, they will feel good about. So it's important to be ready to spend some time because they may have questions to ask. They may want to know what are the treatment options, where can we take the patient, what are the which hospitals treat our condition. So they will have a couple of questions to ask you, and for that you will require to spend some time with them. And therefore, please manage your interruptions like phone call and visitor or anything that you need to do urgently, but you should be ready to spend some time with them. I'm repeating it once again. Please do not delegate. A lot of time we delegate to our juniors. We say, you do it, you go and talk to them, you explain to them. That's not a good idea. I think the treating doctor and the senior most doctor should be actually doing the breaking of bad. Coming to the place, where do we normally do it? Dr. Vijay, in government setup, where do we do it? Do we have
Ma'am,
a
we don't have a specific room. It's actually where it is possible. It's most of the time it's in the OP only.
And that's the reason why sometimes when we are doing it in an open place with others around, it becomes risky. One, because when we are interacting with the patient in a counseling room or in a separate place, it's only two of you who are doing the talking. In case a patient becomes aggressive or starts crying or even says something like that, you did not took prompt care and it's your fault, you did not attend to my patient properly, so you will still maybe quietly take it. But when the patient party talks this in open and there are others who are overhearing our conversation, we feel bad and we feel accused, so we also kind of react to it and also aggressively respond to it. So it's always advisable to make sure to sit down at a separate place. So maybe we don't have a place as of now, but if you will try to look at a place where you can, sit separately with the patient party. See, in OPD, I understand if it is OPD, then maybe you will be doing it in OPD, but then at least there should be nobody, like others who have nothing to do with the patient, who should not be around when you are breaking the bad news or when you're talking about their diagnosis. Otherwise, I think it's always a good idea to have a separate counseling room where you sit down and talk to them, where you and the patient party is comfortably sitting. Then it's very important to ensure their privacy, because a lot of time you will be sharing information which the patient would not like to be sharing with others. So here I want to ask, do we ask the patient, whom would you like to share this information? Do we ask? Do we ask? Because what the guideline says is very different from what is the practice, if I'm not wrong. See, guideline says ideally we should share the information with patient, and rather we should seek patient's permission before we share with anybody, or we can informally or formally ask, whatever the diagnosis or the reports are, whom would you like to share this information? But I think in reality, it's usually the patient's family who first gets to know, and then we talk to the patient. Am I right?
Yes.
Dr. Abhishek, I think you wish to say something. Please go ahead.
Ma'am, I think if it will be definitely, it becomes, we ask the patient, I ask the patient if it's HIV diagnosis. Nobody wants to share it with the family. In the ICU, well, there is no real scope. If somebody is already serious, it's always the patient's relatives who come to know about it.
Yeah.
But generally in the OPD, if it's anything else, I think if somebody is alone, I ask them if they want somebody to be present, or else it's always generally two of them who are always there. So
yeah,
it happens like that.
Usually in OPD, patient will always come with an attendant.
Yes.
But then I mean, how do we check with the patient? Would the patient like to discuss their diagnosis and their reports in the presence of the other person or no? Is it important? Somebody else?
Usually for HIV, we always take it with the patient one-to-one, and then only after
That's a
discussing only
different
the
case.
data.
I think that's very important, where we first discuss with the patient, and a lot of time we have to, of course, I mean, that's but otherwise normally in OPD, if the patient has come alone, and if there is something, for example, mother comes for antenatal, and then you suspect IUD, would you break that news to the mother, or would you wait for some family member? Or if it is an unwed mother and she is diagnosed with pregnancy, then would you discuss with who is there? So can you see the two different situations?
I think it is more individual based, because if it is unwed mother, it is the mother, like the girl, who has to know it first and then
Yes.
It's
decide on.
minor. It is minor.
Minor, it becomes a medical legal
Intimate
case.
police.
That's what I'm saying. What do others
Yes.
say? What do others say?
We will have to inform the parents.
If she doesn't disclose her identity, if she doesn't share their details,
Because many times those who are practicing private obstetricians, they say that we have girls coming from school directly and asking for MTP and all. They don't want even the parents to know about it.
yeah. So these are situations where you really need to be in the know of what is right and wrong legally. Because if we don't know, and if we go wrong, we can be, in trouble. It's very important to know what do the law says about it. So a lot of time when we are talking about patient's condition and the attendant is just a friend or a neighbor, so we really need to first ensure, should we be discussing these details in the presence of the other person or not? That has to be clarified. That was the point I was trying to make. So you can involve people like, maybe patient's attendant, if you think and the patient is okay, or a nurse or a social worker, even your own colleague can be, available when you are breaking the bad news, to handle the situation. So things like facial tissue, glass of water, if you can, keep it handy, it helps to show your human side, and also the patient might need them when you will be kind of breaking the news to them or talking with them. Now, before you start giving the information, it is important to assess what is the starting point. So maybe when you ask something like this, what do you know about your condition? What has the referring doctor told you? Or why do you think we did this test? So this will give you an idea how much does the patient know. Because if the patient has been referred from another hospital, then of course the patient has an idea. There's some tests were done and then they were told that you need to go to a higher center. But a lot of time they have just no idea, and they have come to know, they have come to you, on their own. So they may not be even knowing what to expect. So it's very important to assess their starting point and their information need. There will be situations where patients want to know everything, and there will be situations that say, I don't want to know all the details, just treat. So ask what does the patient want to know, and also make sure, is the patient ready to receive the information? Because if the patient is not prepared, and if you will suddenly break the news, it can affect the patient, and patient can get overwhelmed. So if you see the patient is unprepared, or there's nobody with the patient, and the information is something that that can seriously impact the patient. So it's always good to reschedule it, for a dated date, but not very late. It should be done as early as possible. And then also you can check with the patient whom all the patient wants to engage in discussion. Because as I said, a lot of time when you know that there is something that you will have to tell to the patient, but it's important to check with the patient whom the patient wants to be part of. So if I talk about what do patients want to know and how much they want to know, studies have shown that almost 100% of the patient wants to know about their disease condition. Especially, like, for example, in this study, 98% of the patient wanted to know if the illness was cancer. and then as much information as possible. So that shows that patient information need is mostly they want to know everything. So when it comes to what patients want and what they receive, the gap between the two, almost 56-7% patient wanted to discuss their life expectancy, but only 27% actually did. Similarly, 63% of the patient wanted to discuss the effect of cancer on other aspects of life. But when it comes to discussing the impact of disease on their other aspects of life, only 1/3 of us actually are comfortable talking about it. So when when you're talking to the patient, you will actually be able to identify things like illness denial, wishful thinking, unrealistic expectation of treatment. Very often you will see somebody might not even believe that no, I can't have this. I never had condition like this. Or they may have a wishful thinking that this is nothing very big. This can be treated, or this my brother has or my mother has, and they may think that this is not a very big thing, or they may have unrealistic expectation from the treatment that I will be 100% okay because I have come to a tertiary care hospital. So when you identify something like this, it's very important to address these, appropriately. In case if there is some misinformation, we must correct that misinformation right then and there itself, because otherwise they'll be building on that. And then if you can sense something like denial and or not being ready for it, so we'll need to tailor the bad news so that they get mentally prepared. So when it comes to delivering the bad news to the patient party or patient, it's important to be sensitive, but at the same time we need to be straightforward. We should not minimize the severity of the condition with the idea that we want to soften the blow, because it can create vagueness and confusion, especially if you see we are trying, I hope we'll be able to do, let's see what happens. So when you say things like this, they may get confused and they may think that there is still some, there's a possibility. As a result, it can cause confusion and they may blame you tomorrow for not telling them the truth. So it's very important to balance between the sensitivity and honesty. Also, it's not advisable to give any, precise answers. Sometimes when patients ask, how much time do I have? And I've seen people saying 6 months or 1 year. So it's not a good idea to, give any precise answer. It's always advisable to say something like in cases like this is normally the time that patients are able to, we have seen patients living for this long. So they get an idea about the range, but one should avoid giving any precise answer to that. And then it's important not to take away all hopes and, find some reason to be optimistic. Otherwise, they may lose complete hope and then be devastated. So while you are doing the explaining them about their disease or whatever the situation is, please make sure that you use simple language and avoid all kind of technical jargons. Because anywhere, if they don't understand, it can cause confusion and miscommunication. So avoid single steady monologue where you are doing the complete talking. Rather than them, try to create a dialogue. So when you create dialogue, you get to see how much they have understood. Are they really with you? Are they able to absorb what you're saying, and how they are processing the whole information? So for that, pause frequently so that in case if they wish to ask something, they get a chance to ask. And also you can observe them and see how it is impacting them. So your body language and silence will play a very big role to facilitate the discussion. For example, if you are continuously talking, again, they will not get an opportunity to ask or say something in between. And also in case if your body language shows authority and intimidation, they might be too, scared to ask you something, or they may be hesitant to clarify with you. So body language as this, okay, check for understanding, because as I said, lot of time you must have explained them everything. And then in the end, they might say, Doctor Sahab, bach to jayega na patient. So when they ask you a question like this, that means they have yet not understood completely, and they're still having an idea that the patient might do well or come back. So this we have discussed earlier also about the body language. Again, words play a big role. We have to be very careful with words. Because lot of time the wrong wording can create conflict and can upset people and can end up into aggressive reaction. Tone of voice and body language plays a very big role. So what associated body language will help? What do you say? What kind of body language do you think will help in this situation? What all should we keep in mind?
Slightly leaning forward, showing
Okay.
interest.
Okay. What else?
Neutral,
Forward.
open expression.
Okay.
And
Neutral, open expression. Okay.
Nodding head.
Avoid taking any calls.
Avoid taking any calls. Absolutely. One should avoid taking calls. Absolutely. Composed. Yes. Calm, composed.
Looking into the eyes.
Making eye contact. That's very important. Why is making eye contact important?
So that we can judge.
It shows that we are listening to the person and we are interested in what the person is saying.
So that shows we are attentively interacting with 100% of attention. So what does avoiding eye contact communicate or can communicate? If you don't make eye
contact, will
contact,
say that we are saying
Lack
that
of confidence.
we avoid eye contact and say something when we perceive that we are not telling the truth or we are hiding some information.
Either we are hiding something or we are not interested or we are not confident. So all the more important that we make proper eye contact with the patient so that one is of course that communicates compassion from your end. But at the same time that shows your confidence that you are, you are sure of what you are sharing. Then what else? Anything else? I can see
avoiding frowning or inappropriate gestures.
Definitely. Facial expressions play a very big role. In case if any expression of frowning or anger or disagreement comes in, that can upset them and also miscommunicate that probably you are intimidating them in that concern. So body language, like normally we greet or if they greet, we respond to their greeting. Eye contact, we have discussed. Maintaining open posture, but that shows that we are, open to discussion. Leaning forward, you have already mentioned. Tone of voice plays a very big role. If anywhere you are sounding authoritative or intimidating, they will not feel comfortable. Also, at the same time, we have to allow them to speak because they want to express. Sometimes they would just babble something that may not actually have any, any particular thing to talk about, but then they might just speak out of anxiety or they're being overwhelmed. Listen attentively to what they are saying. Also, at the same time, like you said, nod. Yes, because nodding indicates that I'm listening to you and I'm understanding what you're saying. Even their emotional reactions has to be kind of accepted without being too reactive. So we don't have to react to everything that they say. When they're upset, they're overwhelmed, they might say something that may kind of slightly upset us, but that can be overlooked unless it's a, kind of an accusation and they're just insisting on it. Because even allowing that kind of emotional expression, gives them comfort that there is somebody who's understanding them. So verbally and non-verbally, we can comfort them. Would you touch the patient party? Would you touch the patient party, your patient? Only if we have good rapport and they are, aligned with us, they are okay with that. But in case if they are not seeming to be, okay, then it's always good not to do that because that itself can upset them and disturb them. So one should avoid touching. But non-verbally, of course, we can communicate. Now, how do you start the conversation? How do you start the conversation? Any particular way? Dr. Som, any particular way you start your conversation?
If we are going to talk about some test results, then we can ask like, would it be all right for us to discuss about your test results now? Or I have your results with me. Is it okay if we go through it?
Hmm.
So some sort of thing we can start off.
Okay. Dr. Abhishek, anything you wish to add to it?
I generally would ask them how they're feeling today, how their symptoms has been since the last time I met or spoke or discussed or shared the reports. Are they feeling fine? How are their spirits in general? And then slowly ease into the conversation. Okay, well, now that you're feeling better, let me discuss what we are here for. Are you okay with that?
Sometimes a warning shot will be give an indication how to proceed with the conversation. Like, I regret to inform you that the results are not as we hoped, which may be difficult to hear. So, is it okay? We can go through it. So, when we fire such a warning shot, something, then there is no need to reason to drag them along with false hope. And then if you have even mixed news or something, it's okay to tell us, and then how they react to it, and then we can take the conversation further from that point.
So I'm just sharing some ways people start their conversation. I don't know how many of us are really using this in our communication with the patient. I'm sorry, I have a bad news to share with you. Unfortunately, your reports are not okay, or I feel bad to tell you. Do we use any of these statements? Or they are too formal.
It depends on the understanding ability of the patients. Whenever we say, we start that I'm afraid the news is not good. Many times the patients think that the worst possible news is what we are going to say. So sometimes they react very in a very different way. So we have to be very careful where we are going to use this.
I think the positive terms should be used then.
Civil, when you use positive terms, the risk is that they might take it as, things are not that serious. So there is a risk of confusion. So one cannot say that, don't worry, everything will be fine. We are working on it. I'm sure we'll be able to come out of it. So all these things can really create a lot of, confusion. And then tomorrow patient might blame you for not telling them the truth. So therefore, one has to be really very careful about, wording what you are saying. So it has to be clearly communicated. Of course, we have to give them time to absorb, and we have to demonstrate empathy, where we kind of let them know that we are with you in this, and we will see what best can be done to alleviate their suffering. But we can't give them any false hope or false assurance. That is very, very risky. Very, very risky. So we have to be very careful. So how does patients? How does bad news hit patients? What do you think? How does that hit them? How do they respond? What exactly happens? What exactly happens to them when they hear the bad news?
It could be in a phase of denial that it cannot happen to me, or sometimes they'll be shocked and afraid, anxious.
Yes.
They could be confused.
Yeah.
And become some people get angry or cry, and then they become
they want to blame. They want
aggressive. Sometimes they become aggressive as well.
They'll cry too, ma'am.
Sorry. Go ahead, please.
They will cry too.
Speechless for sometimes.
Dr. Abhishek, 1 second. Somebody was answering something. Then
Ma'am, I said they will cry. Some people
they
start crying.
Cry. Absolutely. I think that's a very common response you receive from patients. Yes, Dr. Abhishek, you were saying something. Go ahead, please.
Many of time they become very numb to the situation. Like totally, they don't react or show any response. Mostly like in a state of shock. So it takes them some time to even get to where they are currently.
So actually, bad news results in a cognitive, behavioral, or emotional deficit. So like you said, numb or shock or suddenly quiet or blank, that's because they they don't know, and they take time to process that information and to absorb it. And therefore, to look at, they will appear that they are just not knowing how to respond or react to it. Somebody was saying something I could overhear, but then I stopped. Anybody wants to add something here?
Many times it is that they may deny, they may show denial also and say
Maybe
that
sometimes.
Yes,
maybe the report is wrong. We would like to confirm again.
absolutely. So that is actually there, again, there's a grief process, you can say. So grief cycle. So that's denial is the first state. That is dabda. We'll be talking about that in a minute. So you're right. Initially, there will be a deficit where they are kind of confused, or they are blank, or they don't know how to react. So, I mean, you can't change the news, but at the same time, if we can give them realistic hope, and make them feel better, or if we are giving a cold behavior at that time, that can really hit them back. So studies have shown that a lot of patients, almost 50% of the patients, respond with shock. Almost again the same number of the patients have also reported being frightened. Then almost one fourth of the patient reported sadness, 40% of the patient accepted, and 50% of the patient said that they were not worried. So you can see how different people respond differently, react differently to this situation. The patient might react by suddenly crying, becoming silent, or asking you, "Are you sure?" or doubting, "This is not my report. It could be a wrong report." Or they might say something like, "Please don't tell my wife, don't tell my husband, don't tell my parent." So they might say, or even the family might say, don't tell the patient. I mean, these are the way you will see them reacting to the news. The internal psychological response, or the grief cycle, or cycle, is basically called dabda. That is denial, where they don't believe that this is their report or it has happened to them. Then the second is anger, unhappiness, or being aggressive or revengeful, or they may even blame us. So basically, they are angry and unhappy. Why me? Why has this happened to me? Or they want to blame that you did not take a timely action, you did not refer us on time, you wasted our time, you did not attend me properly. So that's how they would like to blame others for what is happening to them. Then third stage is bargaining, where they may actually request for second opinion, or they may say, "We are ready to spend as much money as you want, but please look after my patient." Or they may say that we are ready to take the patient to any hospital where you think we can save the patient. So that's basically they are trying to bargain to see what best can be done to save the patient. And then once the reality sets in, then they become quiet, and that's more like, state that's called depression, where they feel sad and bad about the situation, and finally they accept and they come out. So this whole cycle is called dabda, and it is very important to be with the patient right from state one to when they start accepting it. When we leave them in between, and when we don't give them time to process and then become okay with it and accept it, we are taking a chance that they might go out, or we might leave the patient or family at that stage, and they get adversely affected, and they come back and start barking. But if you stay with them during this whole process, slowly they calm down and they become comfortable and okay with where the reality is. How do you go about managing these responses? If you see the patient is in denial or the family is in denial, it is helpful to actually provide them information that will help them know the facts. So having ready the reports or referral notes or second opinion notes will help them believe what you are saying is true, and that will slowly kind of give them the taste of truth. If you see them angry and upset, it's important to stay calm and listen to them attentively and be supportive. And at the same time, we don't have to react to everything, because sometimes when we retaliate with anger, that can aggravate. So we have to really, keep a control on our anger. When they are in bargaining state, help them see the reality, because they are actually having an unrealistic expectation that probably money can buy life, or maybe there is a treatment somewhere, and if we can go out and get the treatment, maybe we can save the patient. So a lot of time they will say that we want to try different, medical system. So, I mean, we don't have to be annoyed about it. At the same time, we need to be empathetic and we need to assert and help them see what is the situation and what will work in that situation. When you see them becoming quiet and becoming sad, that is where we need to give them direction and tell them what needs to be done. So, for example, if the patient requires referral to another setup, or patient needs to, be admitted for surgery or for chemotherapy, so that's where we need to tell them what needs to be done next. And when you see them accepting the situation and getting ready for it, that's where we can encourage them and support them and see how they have to take it forward. Now, the one thing through and through that's going to help us is empathy. So if you can showcase that you are feeling in tune with them and their situation, they feel. See, we can't change the situation, but the feeling that there is somebody who understands my state of fear and is, supportive, reduces their suffering. So, what are the different ways we can we can express empathy with them? Can you think of some ways? What verbal expressions can help us express empathy?
Ma'am, two simple words: I understand.
That's a very common thing we say, and that helps also. Absolutely, that helps also, and it's very useful to express something in this manner, where they feel that there is somebody who's understanding my plight. So a lot of time when you say that, I can see you're very upset, and I can see this is very upsetting to you, and I mean, it was something that you were not expecting, and I'm sorry that, I mean, this has happened to you. This would have been difficult for anyone. So when you express in this manner, they get to see that you can see the impact it is having on them. And so these are different ways you can use to communicate empathy. Now, coming to communicating in final hours. A lot of time when we know that there's hardly any time left and the condition has really deteriorated, patient is in ICU. I mean, all systems are slowly failing. So, what care needs to be taken when you communicate, when you are communicating with the family? Can you?
Ma'am, you can just be with the patient's relatives.
Be with
Just
them.
just be with them. I mean, you don't have to say anything. Just be with them.
Okay. Dr. Abhishek, you wish to add something?
I think what we can do is handhold them through their grief, and making it easier for them so that they can spend time with their loved one and not have to battle through the security and all. Just make those kind of processes simpler and easier.
I think that's a very important thing. As I said earlier also, especially the nurses and residents working in the critical care area, they need to be sensitized. Even the security guards need to be sensitized that at least the immediate family members can be permitted to, visit the patient, because these are the last few hours when they can see their family member alive. So for them, we need to be really more considerate and allow them to, see the patient. Anything, Dr. Som, you wish to add to it? And how do you manage if you wish to share your?
So many times in my practice, we end up in either a patient who is about to crash or something, so they end up in resuscitation and so on. So we need to understand the legality behind it, and we need to confirm with the patient whether they want to be resuscitated, or we need to have an discussion. So that sort of discussion, if the patients are and relatives are understanding, then it becomes easier. So we can actually, if the when I was working in UK, it was very easy for me to communicate with the patient at the end of life, to talk to them about it, because they have a respect form about it. So it gives a choice to the patient how they want, whether they need a palliative care or they want to choose all options explored to keep them alive, or they just need a proper end of life care, so that a palliative care, so that they can spend time with the family with just pain relief, and they can write a will and spend the the final hours or final days with their family, surrounded by family. So the quality of life is important for them. So many of the people. So that was an.
I don't think in India we are still.
We don't have.
We
We still have, but legally we don't have any other any options like that.
No, yeah.
Yeah, and but many times educated patients, they do ask for it. That do not intervene. I would like to go pain free.
Peaceful, yeah, pain free.
Yeah, that is the only thing they expect with the surroundings. So at that situations, and then we do get concerned that they do not get for need for any interventions, but then we give appropriate palliative care, and then the main important thing is surrounded by their patient relatives, and how they wish their final days of life to be spent with everyone. So if we talk with a compassionate manner, with the empathy, with the validation of their emotions, I think the communication will be very easier. I think it's very easy said than done. It means quite a lot of practice. In initial days, it was very difficult for me to.
Absolutely, it's not easy. It's not easy. Absolutely, I agree. And at the same time, sometimes patient's family says that we want to take patient home. They want to remove the patient from ventilator and they want to take the patient home. And though we know that, I mean, patient is not going to make it, but then we are hesitant to agree to that, where they say that we want to take the patient home. I think even that decision can be respected if you think, I mean, if that's the last option, then why not patient die peacefully with the family around and then at home? Even that's something that we can allow. So I think that's a very tricky communication and tricky situation, where you have to, understand patient's family and patient's life. So they may, where you see that the death is inevitable and it is recognized, the patient is actually, all systems are failing and patient is not going to make. So there, I think compassionate honesty and informing them what is the situation, and then also allowing the family members to meet the patient. As I said earlier also, that's very important. We need to be a little more understanding and considerate. Also, the family needs, the family's need for support also need to be evaluated, and they should be provided whatever possible support you can provide. A lot of time, they want to do something for the patient. There are certain rituals that they want to perform, while the patient is still alive. So how many times do we really, in how many setups do we allow something like this?
Usually it is allowed, and
Aparna, in your
always
hospital?
respect for the rituals which they have. Sometimes it is that, we want patient to touch certain things which can be given to poor people, or calling some religious person to have the last prayers and all those things.
So that's
It is
something that
permitted.
we need to be more accommodative now. Of course, some hospitals I do see that they allow, even for some prayers and some, even like, for example, in Hindus, they like to give Ganga Jal to the patient because they feel that that's the thing that they want to do. So what I'm saying that we need to be more accommodative to these needs of the patient party, something that does not disturb the decorum of the ICU or working of the ICU, but something that is okay for the patient and the family. So coming to announcing death, as said earlier, it should be done by the senior most person in person, because a lot of time when it is done by somebody who's not treating the patient, it will be very difficult to explain and also connect with the patient party at that moment. Being honest is important. I know in most of the hospitals, we start the resuscitation and we inform the family that this is the situation and we are trying to resuscitate, so that they slowly get prepared, and then you give them little bit of time to, mentally get ready. And sometimes they want to come and see the patient. Again, you have to take a call. Can you really allow them to come and see while you are resuscitating? Normally, I think we discourage that and we tell them that it will not be very pleasant sight for you, so it's better if you wait out there. But if they insist, maybe for a few seconds they can come in and see. But then it's very important to being honest with them and being there with them, because if in those hours, if they can sense that you understand their plight and you are with them, they feel happy that there is somebody who's understanding my situation. Ask about their cultural or religious rituals. As I said, that if they want to do something which is permittable, we should be okay with that. And then also, when you are going to talk about something like funeral or autopsy, we need to be sensitive when we are talking about that, and we need to see that it's going to impact them. And then, in case if you see any unusual grief reaction, we need to be careful, because sometimes they might overreact. They might we have seen people becoming very upset and then going and committing suicide. We have seen such cases, or aggressively reacting and hitting people. Both we have seen. So we need to watch for those unusual grief reactions, and then wherever need be, we need to elicit support system. As I mentioned earlier, also that role of residents, nurses, and other paramedical staff in understanding and also being accommodating to the family need is very important. So we really need to sensitize them to the plight of the patient party, so that they are more accommodating. Now, coming to the clinician's perspective. So what do you think are the clinician's perspective? What do they go through? What do they go through? What is, at the back of their mind that's continuously going?
They also must be going through some sort of stress, ma'am, handling such situation. And yeah, definitely.
I think
Clinicians are the second victims, actually. The first victim will be the patient.
Exactly. I was about to say this. I think even seasoned clinicians find it difficult to break the bad news. How much ever you have done, but at the end of the day, when patient dies, there is a feeling that, oh, we did everything for this patient, but we could not save the patient. So a lot of time we have seen that they are very uncomfortable about going and breaking the bad news, and also the expectation the patient had, the family had. Those expectations are now they haven't been able to fulfill. So like Mr. Vijayaraj says that they feel disappointed. Absolutely, because after all, you have put in a lot of effort. So there's always a disappointment. Then there's also a fear of destroying the patient's hope. They were hopeful that they will be able to save the patient, or patient will do well. But unfortunately, when patient does not make up, they feel disappointed. Then there's a feeling of inadequacy in the face of uncontrollable disease. Because sometimes when you know that something that you cannot do anything, for example, we have recently experienced COVID-19. So that was something not in our control, and we have seen patients dying right in front of us. So one would feel inadequate in the face of that kind of a situation. Dr. Som, you wish to add something?
Yeah, there's an entity called the second victim syndrome, where clinicians who had to break bad news, not necessarily death, but it could be any of the events, adverse clinical events, which are anticipated or unanticipated to the patients. They have a burden of anxiety for prolonged periods of life, and then they become very difficult to, they had an insecurity in their mind, and they find it difficult to give an adequate care to the subsequent patients that they are giving. Mm-hmm. And this is common in patients who are in doctors who are giving, healthcare professionals who are working in acute care settings like emergency medicine, intensive care, anesthesia, and obstetrics, and neonatal ICUs, and so on. Mm. And the second victimization is much more common among nurses, which we never talk about, or which we never overlook into it, because they are the ones who are taking care of the patients day in and day out for a few weeks, and then all of a sudden they end up resuscitating them, and then they lose them, and then People who are very dedicated to their job, they will be thinking that what could have been done better by me? Have I missed something? Or so this in this bed, this patient was there for the past 2 weeks. Now he is not there. So they will benefit from psychological counseling and support. So that's what the literature says.
Yeah, absolutely. So true. Yeah.
Ma'am, may I add something?
Please go ahead. Yeah.
It's very well summed up by Som sir. But one more thing is that very often we do it in the course of our daily work. And when we really come out of duty and all, it hits us really hard. And there is actual psychosocial as well as physical effects of this. It also contributes to burnout in some way. And it leads to a lot of self-questioning, and it lingers in some way while we continue to function in our daily as well as professional life.
Absolutely. I completely agree. Because you may face it very bravely, but inside you definitely, start doubting yourself. Or sometimes if you miss to do something, you feel bad about it, that I could have done this or I should have discussed with him. But we have also seen a lot of doctors are not affected by, what they are doing, and they do it in a very mechanical manner also. Even this is the truth of life. And we see them doing it in a very casual manner, and that sometimes patient party feel very bad about the way they have been given the news in a very mechanical manner. And I think you will agree with me on that.
Agree, ma'am, but sometimes it catches up with them.
Absolutely. So a lot of time we are not even prepared to manage. For example, as I said, dabda is a very, a regular thing you will see in your patients. They will be denial, angry, and then. But do we know how to handle it? Are we prepared to handle it? Do we spend time to handle it? So when we don't, we are not prepared for it. So definitely we don't know how to go about managing and mitigating this situation. And sometimes we paint a very optimistic picture. For example, if there's a procedure which can be done in OPD or it is done in the OPD, so it's a small procedure. If it is an OPD procedure, it doesn't mean it's risk-free. So I remember a lot of, I wouldn't be naming the eye chain, but it had this tagline, "Ghar se aaiye, surgery karwaiye, office jaiye," for their, eye surgery, for phacoemulsification. But I'm sure once they had some nucleus drop and then vitreous hemorrhage, they realized, no, that's not the right way of advertising. That's why, because if we try to, give a very, very, risk-free picture, and if something goes wrong, then it becomes very difficult to explain what exactly happened. So I think we have to make sure that we give realistic expectations. You wish to say something, Dr. Punia?
I just wanted to add to this, that to the toll it takes on the person delivering the news, that is the doctor, there is also another component. Our own performance anxiety in these situations sometimes makes us impatient for responses which are not ORI. And so we rush through it sometimes, or it hampers our own performance. So we have to remember that it's not about us, but it's about the patient.
Yeah, absolutely. So giving a realistic expectations and accepting professional limitations. How much ever good we might be, but still we know we can't 100% be sure of what will be the outcome. Then learning how to control emotional reactions, because the more we will react to the situation, more likely we are going to complicate the situation. And then keeping the family updated will help you to handle their emotions time to time, and also prepare them for the eventuality. And then making sure that you document all communications. So the thumb rule that we have to follow is document what you communicate and communicate what you document. So that way you will be kind of, making sure that you are fulfilling the responsibility of documenting all communication. Now, what are the common mistakes we do in breaking bad news? What that we have seen across?
Being very blunt.
Being very blunt.
Without any emotions and empathy.
Yes, lack of empathy. Absolutely. Yes, Dr. Abhishek, go ahead.
Underestimating or overestimating a patient's reaction.
Okay.
So sometimes we sometimes we may think that this patient is looking very tough. They have been behaving very tough, so they will be able to take the news, but they are the ones who crumble in front of you.
Yeah.
So, yeah.
Agreed. Yeah. So that means we write estimation of their ability to process it has to be done. Okay. Anything else? Somebody? I think this question anybody can answer because you must have seen people doing this. So, what are the common, practices that you see?
Being unprepared to deliver the bad
Yes,
news.
a lot of time we are not prepared to break the bad news, so that can actually go wrong. That can actually create. So a lot of
Not,
time,
not
yeah,
ensuring privacy.
privacy is not looked after, and we do it in a very casual manner in OPD or in the presence of others. Agreed. What else?
Being in
Being
hurry to accept the response from the patient party.
Sorry?
Being in hurry.
Okay, being in hurry. Being in hurry. Yes, that's also, we have seen a lot of time. People are do it in a hurried manner, or they say, I'll do in the end when I'm about to leave. We have, that can complicate. Yeah, go ahead, please.
being condescending or judgmental, especially if you're telling somebody they are HIV positive or something.
Oh, yes, that's also true. Then we blame them for their state of affairs and we hold them responsible for their.
Or for that matter, if it's a teenage pregnancy or something like that, being very judgmental about it.
Being judgmental, yes, being judgmental about it. Or
And
doubting
sometimes not
character. Yeah.
sometimes not giving them opportunity to express their feelings,
Yeah.
their
That is,
concern.
yeah, we are not making them comfortable to come out with what they are doing. Absolutely. Thank you. I think good points that we are noting down. So a lot of time we have seen that people try to avoid breaking the bad news as long as possible. They would not communicate to the patient or the family. So they will actually, not do it. Sometimes even hoping that someone else will do it. So they would like to, put that responsibility on somebody else's hand. Sometimes they don't tell the complete truth, or they are too economical with truth, and as a result, they don't share the facts completely. Sometimes they don't pick the patient's cues. They can see the patient is getting upset or is not accepting or is not understanding, but they would just do it in a mechanical manner and then doing it the activity in a mechanical manner. So we see these kind of errors besides what all you have mentioned. And we have to be careful that it has to be done in a sensitive manner, in a peaceful way, letting the patient party and patient understand and accept it. So once you break the bad news, patients fear that they are going to be left out, they are going to be abandoned. So it's very important to help them see that they are not going to be abandoned, but they will be needing to go to another center in case if we don't have that facility to treat them. So we have to establish a treatment plan with them. Whatever their current symptoms require attention, we treat them simultaneously, and we also discuss the next treatment plan. And in case if they want to come up for follow-up, so we establish a time for a follow-up appointment in case if they need to come back to us. In case if they need to go to another hospital, then we need to arrange for appropriate referral. Give the contact details if possible. If you can call and communicate, and then also give them the name of the person with whom they have to connect. It makes it easy for them to connect further, and also hope that they will get proper attention and care. So involving people like family, friends, social workers, spiritual counselor, this will help in looking after the patient's other needs other than the medical intervention. So at this moment, their psychological, social, emotional needs will be high. And maybe as a clinician, you may not be able to fulfill that. But if there are people who can look after these needs, you can ensure that these needs are looked after, and it becomes easy for you also. So to just to summarize what we have discussed, it is most patients want to know, and if done rightly, it improves doctor-patient relationship. It helps patient and family cope with this situation, and it fosters a collaborative relationship between the patient and the treating doctor. It can also prevent aggressive reaction. So 6 steps of breaking bad news that we have discussed just now. Please prepare before you go and break the news. Find out what the patient knows. Find out what the patient wants to know, so that accordingly you share the information. There will be emotional reaction. Please be ready to respond to those emotions and manage them effectively. and then plan and follow up so that they feel that they have not been just left in between. Disease and death, it's very scary. I think when we personally experience something like this, we get to understand what the family was taken. I don't wish anything of that sort, but personally, I think I got a close taste of it when I lost some of my family members, and that makes us more humane in our approach. So with this, I think I'll stop the discussion here. Thank you for contributing and participating to the discussion. I think we had a wonderful points coming from all of you, and especially we have people who are already in critical care areas. So from their input, we got to understand. And I think role play also made us feel that it's not easy. It's a difficult task being done by our doctors, and we need to be more empathetic with them, especially without any formal training and mentoring. If they're doing it, it's really commendable. But yes, with training, I think we can do much better. So make sure that you train your juniors, your doctors, your nurses, and let them be more sensitive and you know, empathetic with the patient. Any questions about what we have discussed in now? Or any comment you want to give, a feedback that you need to, quick feedback you want to give? Okay, so if there are no comments and no feedback, I know we have had good discussion, so that's okay. I think how many presentations we have? Anu is presenting.
I am presenting, ma'am.
Yeah, Anandita is presenting. So, Jana, you will present next time?
I want to next time or do it today?
Last session.
Okay, fine.
Yeah, also, good that I realized next session, I can't hold it on 17th. I have a wedding in the family on that day. There's a function. Wedding is on 19th, but 17th is a function. So can we hold it on 18th? That is Thursday. If it's okay with everyone.
Okay, ma'am.
Thursday 18th.
Okay, from my side.
Okay. Thank
Yes,
you.
from my side too.
Thank you. I'll post it in the group in case if you have challenge on Friday, then we can, Thursday, then we can look for another day. Otherwise, we'll go ahead with 18th. Next session will be on 18th. So I'm changing the setting now. Anu, you will present first? Okay. So after Anu, we can have a presentation by Anandita. Jana, you will present next, and then Dr. Bijoy, you will also present next, but we need to discuss your presentation.
Yes, ma'am.
Yeah.
All the best, Dr. Anu.
Thank you.
Anu, any challenge at your end?
No, ma'am. No, ma'am. Give me a second, ma'am.
Okay, sure. No, suddenly everything became quiet, so I thought, is everything okay?
Hope everyone can see my screen.
Yes, we can.
Thank you. Okay. Good evening, everyone. So, hope I'm audible too.
Yes, you are.
Okay, fine. So today I'm going to present on Socratic questioning, which is a famous facilitative approach. So before going into this, I want to put a
So,
summary
Anu,
on
will
this.
you be going to slideshow or you will be using the same?
Oh, okay, ma'am. Sorry.
Yeah, it's okay. Thank you.
Okay. Socratic questioning is nothing but it's a type of or way of teaching or a facilitation method which we use for stimulating critical thinking in the participants and also to explore the ideas to uncover the underlying assumptions too. So as it named after the ancient Greek philosopher, as we all know that Socrates, who used to question more to his disciples rather than teaching. So this is a small clip ad where I want to show you how he used to question their disciples. Like, so already Dr. Som has presented on reflective question. So we thought that reflective questioning and Socratic questioning will be the same, but a little difference, I can say a thin line is there. Reflective questioning is nothing but it is going to guide the individuals to reflect on their experiences, emotions, and actions, as well as the Socratic question mainly focuses on individuals, and it stimulates the critical thinking and also analyze the ideas, beliefs, and assumptions. So 6 types of distinctive Socratic questions are there, like questions that clarify, where the questions that probe the assumptions, questions that probe the evidences, if anything happens, why it happened, why you came to this conclusion. We can probe by asking for the evidences. Questions about the perspectives and questions about implications and consequences, and questions on the questions, which is a very frequently used method. And practical tips for using this Socratic questioning is like always you have to start with the open-ended questions, and you have to encourage, explore, and inquire the participants. As a facilitator, you have to listen actively to the responses, and you have avoid leading questions, or you have to avoid giving answers or hints to the participants. You have to get the answers from the participant by directing them towards the discussion. It's nothing but facilitating them. And you have to create a safe and supportive environment, like mostly when students are answering or when they're forming some questions, there will be some people will be joking on them. All these things you have to avoid as a facilitator. Even if something is going wrong, as a facilitator, you have to be in control to that particular discussion. You have to be very patient and you have to allow time, because it is very time taking process. And always after every session, you have to provide feedback and encouragement to the participants. And what are the challenges we face in the Socratic questioning is like you have to require skills as a facilitator. You need to practice asking and forming effective questions. Effective questions throwing towards the participants are very, very important as a facilitator. So you should know how the questions should be formed. And some individuals may not find it uncomfortable because you are asking probing. It's like inquiry type. So maybe some people won't be comfortable. And it's already, I have discussed, it's a time consuming, especially in group settings. And this is the beauty of this questioning is like you can add so many participants. You can continue from the morning to evening on a single topic, because it's just probing questions and questions and questions. And it may not be suitable for all learning styles. Especially we use this type of Socratic questioning in simulations when we do simulation activities. And with this, like I want to conclude this presentation with this slide. Socratic questioning offers a dynamic and effective approaches. And when you are doing this, the primary goal of the Socratic questioning is critical thinking. You have to stimulate the critical thinking, and you have to empower the individuals to engage deeply with ideas and concepts. And to promote this Socratic learning, you should be patient, and you have to be having lots of patience. And with this, I want to end this with this slide. I cannot teach anybody anything. I can only make them think. This is the thing which Socrates has told us.
Thank you, Anu. Can you stop sharing? Yeah.
I think I'm too fast, but okay.
Yes. So I was hoping that you will be doing some exercise with.
Actually, I thought to show some video, but last time when Abdul Razak sir was presenting, I thought some technical disturbances are happening. So I don't want this to happen, because you told me to complete my presentation within 8 minutes. Hope I am in time.
Much in time.
Thank you.
4.46. 4.46. Okay, so just to ask you, what are the do's and don'ts in
Pardon,
Socrates?
ma'am?
What are the do's and don'ts? What should you do when you are? What should you keep in mind when you are using
Okay,
this?
when I'm facilitating and when I have choose this tool as a facilitation tool, I should be always like I'd simply say that I will be like a policeman only. I have to inquire, and I have a why, how, where, all these things I have to do. And I'm like, if a participant is stuck somewhere where he is not able to answer, so I have to give some time to him. I have to give some hints, but I'm not supposed to give any answers directly. Have you observed something there? So I can give
So that means, especially in a group, like for example, this is a group.
It's a big group. Like
So
when we do
even in
simulation.
this group,
Pardon, ma'am?
even in this group, when we are 10, 12 of us, we have to keep in mind that we don't ask questions that make people uncomfortable.
Yes, ma'am.
So we have to be careful when. See, I use this very often with all of you. I mean, this is the technique I'm using right from session 1
Yes,
till
ma'am.
now. But
The
we have
same
to,
thing even you have used for me also. When you asked me to do some role play, I told you that, ma'am, I'm not in clinical side. So it's like before giving something, you have asked me.
you have to make your participants comfortable. So we have to be careful not to ask questions that could be, disturbing or uncomfortable for others.
I want to give you an example, ma'am. When we do simulation cases, we'll get group of doctors and nurses. We make them as a team members, like especially when you are doing ACLS, we'll be having mega code there. So when we are giving roles to that particular people, we'll ask them like whether they are comfortable in using all the equipments or not. Because when they are in group, they are not supposed to say like they'll feel that we are nurses, we are doctors, we have lots of experience. But when it comes to the case, they won't be able to perform. So to avoid all these things, we will ask them whether they are comfortable or not. Whatever they are comfortable, we'll try to give the same role to them.
Yeah, so we have to check their comfort. Similarly, when we are questioning, we have to be careful in phrasing our question in a manner that it should look like a. Actually, I mean, in a group like this, we can't even ask a probing question. That's not advisable because that's not a. We are not doing any inquiry. We are just making people think. That's what Socrates says, that you have to ask questions so that people reflect and they start thinking and they go deeper into themselves and also the situation. So that's the whole idea that we try to use, and I think we are using it very often in our program. But make sure that we don't ask any question that is look like targeting somebody or upsetting somebody. We have to be careful about that. Any other point if somebody wants to add to this about Socratic questioning? Okay, thank you, Anu. I think it was a wonderful presentation, short and crisp. If we had one activity with this, then it would have made it, more relatable, because then you would have understood that this is how they have to use it. But nevertheless, it was a good presentation. Thank you.
Thank you, ma'am.
So, Anandita, are you ready?
Yes, ma'am. Just give me a moment, please.
Sure.
Good evening, all of you. Is my slides visible and am I audible?
Yes.
Okay. So, good evening once again. My pedagogy is introducing the topic in an interesting way. So, interesting, when I say interesting, it has to be fascinating, engaging, and absorbing for the participants. So, before we start anything, we'll like to do a small crossword related, since the topic is on communication. On communication, we'd like to do a crossword. And I request all of you, since we are running short of time, instead of writing in the chat box, if you can please help keep yourself unmuted and help me. Even group answer will also help. So this puzzle, this crossword which is being given, I'll just read out for as far as the time constraint is keeping in mind. And if you can help me with the answers, please. So once we go to the two across two, the individual who receives the message from the sender, what do we call?
Receiver.
Receiver.
Very good. Coming to 5 across, exchange of information, thoughts, ideas, and feelings. Number 5, sorry.
Communication.
Excellent, excellent. Coming to number 7 across, not influenced by personal feelings or opinions in considering and representing facts. Number 7. Number 7. It starts with O.
Objective.
Yes, yes, ma'am. Now to the next point across 10. Pay attention in 10. Paying attention to and trying to hear what the person is saying.
Attentive.
No.
Active listening.
Yes, listening. Very good. Number 13 across, connection between the healthcare professional and the patient.
Professional.
Professional.
It's the engagement. Moving forward, number 15 across, it's a method that can be used to determine if the communication was useful.
Feedback.
Feedback.
Very good. Feedback. Now coming to down. Number 1, based on or influenced by personal feelings, tastes, or opinion.
Biased.
Number 1 down.
Biased.
No, bias won't
Judge.
fill in. Subjective. Subjective. Yes, someone said subjective. Very good. Number 3 down. Increases knowledge and minimizes anxiety. Increases knowledge and minimizes anxiety.
Empathy.
Very good. Sorry, come again.
Empathy.
No.
Training.
Education. Yes. Just coming to number 4 down. Understanding the healthcare professional will make patients feel accepted. Number 4. One has to be very
empathetic.
Understanding. Yes. Close to that. Dash verbal means facial expression, body language, and touch.
Non-verbal.
Number 6 down. Non. Yes. We all know it's non-verbal communication. Number 8 down. Individual who creates a message to convey information or ideas to another person. Number 8.
Sender.
Sender.
Yes. Number 9. Information, idea, or thought. Number 9. Information, idea, or thought.
Message.
Message.
Yes. Message. 11. Electronic medical records. Electronic medical records.
Or IHL.
It's computers. And 12, the last one is spoken words, written communication. Spoken word or written communication. Yes. So thank you so much for participating. But this was an activity which should have been distributed and given you some time. But within a time limit also, you have done very well. Congratulations to all of you. So this was one of the engaging activity. Now moving to the main slides. Our agenda is introduction of the pedagogy. What is the scope of this pedagogy, advantages and disadvantages, do's and don'ts, and what are the takeaways from after this in this presentation. So introducing the topic in an interesting way, there has to be a thought-provoking question. Could be statistics based on some statistics or some quotes. There could be some quiz questions, interactive activity could be there. There could be very attention-driven image or video, which will later raise to some questions, providing some history or background of the topic. Or there could be, we could also introduce the topic by different viewpoints related to a particular topic which we are going to introduce. There could be some surprising facts that can be presented before the presenters, the participants. We can also use the storytelling method, and we can even share our experiences. Moving to the next slide. The scope of the pedagogy, however, has limitations in the creativity. The trainer really has to think out of the box to make it very interesting. Capturing the attention from the beginning till the end may be a little challenging. There has to be some relevance to the topic. It is not that in that run of introducing the topic in an interesting way, we should not divert ourselves from the topic. There has to be proper clarity has to be there, wherein the complex languages or even jargons should not be used. Audience, it has to be the scope is, it has to be audience-centric approach. It should resonate with the audience's preferences and demography, etc. Now, what are the advantages if we introduce the topic in an interesting way? It will definitely capture the attention. 1. 2, it will be engaging for all the participants. There will be a better bonding with the trainer and the audience or the participants. It will also facilitate the learning process smoothly, and it will increase the overall impact. Now, once we have discussed about the advantages, coming to the disadvantages, there will be distractions many a time. There will be a time constraint, because if we give so much of time in introducing a topic, the entire topic has to be covered, and we all know we have a limited time. So there will be time constraints. It can be too elaborate. The participant might think that this is the training process is getting, the introducing the topic is getting little elaborate. We might lose focus while sometimes trying to introduce the topic in a very interesting way, and there can be a mismatch of expectations. What are the do's and don'ts that this pedagogy involves? The do's, we have to, if we are using this pedagogy of introducing the topic in a very interesting way, we have to be very careful and thorough with the audience. We should be knowing our audience very well. We have to be very creative, because we have to think out of the box to engage our participants. We have to keep encouraging the interaction. Our visual has to be very wisely used. We have to be very clear. The trainer has to be very clear and concise with what is about the topic. We have to also set expectations from the very beginning. And the delivery has to be practiced. It is not that all of a sudden the trainer can go and just deliver. That it has to be repeatedly practiced. Now, coming to the don'ts part, it should not be monotonous. We have to avoid being predictable. It should be in such interesting way, even that it should give us some thought that what could be the topic. So that thought should be there in the mind, and not it is very well predicted ki haan, iske baad to yehi hone wala. We should not exclude the audience. As we said in the do's, we have to encourage the participation, the bonding, so we cannot exclude them. We should not over promise than what is the set expectation. We cannot rush. We should not be in a hurry. And here again, the don't is we should not underestimate the preparation, and the focus should not be lost at any cost. Now, the takeaways, we have to keep the slides visually very appealing with relevant image and minimal and with a consistent design. We have to use storytelling, humor, or personal anecdotes to connect with the audience. Incorporate multimedia elements like videos or audio clips for better understanding. Practice, we have to again and again, this is very important, that we have to practice the presentation to ensure the smooth delivery and keeping the timing in our mind, and encourage audience for interaction and participation throughout the training program. Thank you. Any questions?
Thank you, Anandita. If you could stop sharing the screen. So, any questions for Anandita? So I think use of crossword was an interesting idea. It engaged everyone. Everybody started participating. So maybe this could be used, when you are going to talk about communication, and before that, if you give this as a initial activity, it will engage everyone. And then you can say, okay, we are going to talk about patient communication today.
Ma'am, here I would like to say one thing. With this thing that came into my mind, I already used in my time management practices. So I made a crossword with this time management also. The other day before yesterday, I had a session on time management, and all the participants, they enjoyed. And filling up, then how soon they can fill up, that was also a kind of time, how they're able to manage the time on.
That's very nice. Wonderful. So it's an interesting idea. I think you have introduced us to two things. One is why using interesting activities helpful, and also you introduce puzzle or a crossword as a way to introduce a topic. That's additional. So any questions for Anandita? So if no questions, we close it here. And I'll be sharing the feedback form in the group. I request everyone to give their feedback. And let's meet on next Thursday, that is 18th. Thank you.
Good night.
Good night. Bye-bye.
Thank you.